Welcome to my presentation on current evidences in the management of pediatric acute liver failure. On 23rd of April 2022, the WHO has announced a disease outbreak news, that is a multi-country acute severe hepatitis of unknown origin in children with a higher incidence in UK. There were 169 children with acute severe hepatitis reported by then, out of which 10% required liver transplant and one death was also reported. So let's see what are all the current concepts in the management of pediatric acute liver failure. So first, what is pediatric acute liver failure? So it should fulfill all three criteria. There should be evidence of liver dysfunction within 8 weeks of onset of symptoms. Second is there should be uncorrectable coagulopathy with INR more than 1.5 in patients with hepatic encephalopathy, or the INR should be more than 2 in patients without encephalopathy. And there should not be any evidence of chronic liver disease either at present or in the past. So what are all the challenges in the management of pediatric acute liver failure? This is a condition with a high mortality rate of nearly 70%, and fulminant hepatic failure accounts for 10 to 15% of super urgent liver transplantation, and survival rate without liver transplant is 10 to 40%, but survival with liver transplant is more than 80%. But it's not a easy procedure, and getting a donor is also not very easy. So many die before they get a suitable donor. So alternative liver replacement strategies are under clinical investigations. So what are all the challenges in the management of acute liver failure? So what happens is the liver, which is the major synthetic organ, undergoes a complete damage. So the necrosed liver starts releasing lot of damage associated molecules which stimulate the release of cytokines. So it is almost like a acute cytokine storm syndrome which causes multi-organ dysfunction. Second is the liver is one of the detoxifying agent. So when there is a liver failure, there is accumulation of ammonia which causes cerebral edema and hence leads to hepatic encephalopathy, which is another cause for mortality in acute liver failure. The third is in patients with acute liver failure, there is a high chance of secondary bacterial infection causing sepsis and sudden death. So what are all the outcomes of acute liver failure? One, and which was most common in the earlier days, that is before the transplant era, is death. The second chance is the possibility of spontaneous recovery, but we do not know who will recover spontaneously and how long it will take for spontaneous recovery. The third option and the ultimate is transplant, but we do not know which patient is going to go for a transplant. But till then, that is either till their spontaneous recovery or till they go on to a transplant, they require some form of support to remove the toxins metabolized by the liver, as well as to perform the functions of the liver, and also for modulating the cytokine storm. So this is done by what is called the extracorporeal liver support system. So now, what are all the non-transplant options in pediatric acute liver failure? What is new? So the evidence is from the recent paper by Dr. Akash Deep. The rate of spontaneous recovery in acute liver failure has increased from 28%, which was in the pre-transplantation era, to almost to 73.4% in this transplantation era. So what are all the measures for spontaneous recovery in acute liver failure? So we are not doing anything for promoting the spontaneous liver failure. We are just keeping the patient stable till the liver is able to regenerate spontaneously. First, as the basics, there are some general measures. So whenever a patient presents with acute liver failure, the first and foremost is early referred to a transplant center, and then you need to go for a age-specific etiological workup. There are certain etiologies like paracetamol toxicity, who have a higher propensity for spontaneous recovery, and etiology specific treatment. Then your supportive measures like N-acetylcysteine infusion. This also helps in recovery without transplant. Then hemodynamic stabilization. First choice will be any of the vasopressor in combination with hydrocortisone. And you need to give them a broad spectrum antibiotic since they are very much prone for sepsis, and support them with appropriate products. There is no role of regular FFP transfusion unless there is a clinical bleeding. The most common cause for death is hepatic encephalopathy. So few words about neuromonitoring and neuroprotection. It is like any other child who presents with raised ICP. The head should be in midline position. Avoid hypercarbia as well as hyponatremia, which are going to increase the cerebral edema. Also, you need to target age dependent cerebral perfusion pressure. Then hyperosmolar therapy can be used similar to any pediatric trauma. The most commonly used is hypertonic saline, and you aim for high sodium levels in the range of 140 to 150 milliequivalent. And mannitol is not regularly utilized except when there is a impending herniation where it can buy time to save the patient. And avoid high temperature, that is more than 38 degrees centigrade, and maintain a temperature up to 36 degrees centigrade. In case of refractory increased intracranial pressure, deep sedation or analgesia in the form of thiopentone infusion can be utilized. So these are the general measures which will help in salvaging a patient with pediatric acute liver failure. Then a few words on extracorporeal liver support system. So an ideal extracorporeal liver support system serves as a bridge in case of acute liver failure till a spontaneous recovery or till liver transplant. This is not a therapy for promoting spontaneous recovery. It just buys time. It reduces the waitlist mortality as well as improves the clinical outcome post recovery or post liver transplant. But usually the time between extracorporeal liver support system and liver transplant is very short, so the efficacy of the system could not be assessed properly. Okay, so the role of extracorporeal liver support system. First is you need to remove the toxins which are metabolized by the liver. You have two types of toxins. One is water soluble and another is albumin bound toxin. These two have to be removed. Second thing is it need to do some immunoregulation. As we know, acute liver failure is a cytokine storm, so you need to address that. Third is biosynthesis. The liver is synthesizing all our coagulation factors. So these three functions should be done by our extracorporeal liver support system. No system is such a perfect system as our liver, but we are trying to bridge with whatever is available. So let us see each and everything. So first is a albumin dialysis. So this is mostly described in adult literature, whereas in pediatrics it is not suitable for the smaller size of the kids, as well as it is going to be expensive. But this helps in removing the albumin bound toxin. Even in adults, it has shown to improve the hemodynamics, biochemical status as well as encephalopathy, but there is no survival benefit. Then coming on to the non-albumin based extracorporeal life support system. So one is high volume plasma exchange, another is high volume CRRT, or a hybrid therapy where both high volume plasma exchange is used in combination with the CRRT. So as I told you, the efficacy of albumin based system, there are very few data available in pediatric literature. In adults, though there is a short term improvement, there is no survival benefit. Then coming on to plasma exchange. Plasma exchange helps in removing plasma cytokines as well as adhesion molecules. It helps replacing the plasma factors as well as has a role in immune modulation. There are few data suggesting the benefit of high volume plasma exchange. High volume plasma exchange means 1.5 to 2 times the plasma volume is exchanged. There's a famous adult study where it has shown to improve the transplant free survival compared to standard medical therapy, 58% versus 47%. The European guidelines has incorporated in the acute liver failure management for adults. Then comes a renal replacement therapy. This is very commonly available in a critical care setting. This helps to remove toxins, especially the ammonia. So what are all the literature available in pediatrics? The well-known literature is from King's College by Dr. Akash Deep, where high volume CRRT is used, and this has shown an improved survival with CRRT, 58% versus 42% without CRRT. Again, a reduction in ammonia by 48 hours has shown a significantly improved survival. For every 10% decrease in ammonia at 48 hours, the likelihood of survival increases by 50%. For every 1 hour delay in initiating CRRT, the mortality increases by 4%. The other studies have shown the benefit of a combination of plasma exchange with high volume CRRT. Next is a liver transplant. Liver transplant has revolutionized the prognosis of acute liver failure, causing survival to increase from 10 to 20% to as high as 75 to 80% at 1 year and 70% at 5 years. Though the outcome of liver transplant comparing to a chronic liver disease is less in case of acute liver transplant. Okay, but the decision whether to do transplant or not is very tricky, because if it is too late to transplant, the patient will be unstable for transplant, or there is a chance the patient would have gone for spontaneous recovery, but the patient has ended up being transplanted. So this is a delicate balance. So there are few indications which liver would spontaneously recover, and there are few prognostication model which patient will land up in transplant and who will have spontaneous recovery. The major data comes from the Pediatric Acute Liver Failure Study Group. So in this study group, they have divided into 3 cohorts. The one is who were listed for transplant. The other 2 are who were not too sick for transplanting, or the next one is too sick to list for transplant. The group who were listed for transplant was as early as 24 hours, and the other groups, for the group who was not listed in transplant because they were not sick, it was found that the liver enzymes, that is the transaminases, were very high, whereas the bilirubin was low comparing to the other 2 cohorts. And for those listed for liver transplant, the bilirubin level was very high. So this was the most distinguishing feature in the PALF study group. Also, the etiology of acute liver failure predicts whether the liver is going to recover or the liver is going to require transplant. For example, paracetamol toxicity or ischemic hepatitis or hepatitis A virus, they have a good prognosis and the chances of spontaneous recovery is very high. Whereas there is a group of patients who are unlikely to survive or benefit from liver transplant. Again, it is very crucial to recognize even this group. For example, patients with mitochondrial disease involving multisystem or HLH or herpes simplex virus, where a multisystemic involvement is there, these are the people who are not going to benefit from liver transplant. Hence, a judicious decision making is very important, whether to transplant or wait, or they are not going to benefit from transplant. Next, let us discuss about a prognostication model. So the risk of ending up at transplant is high in children less than 2 years if the peak INR is high, or if the bilirubin levels are high, or if the WBC is high. There is another liver injury unit score which takes the composite score of peak bilirubin, INR and ammonia. And These models predict whether the patient might end up with transplant or they may recover spontaneously. So any patient who meets the pediatric acute liver failure criteria at the earliest contact with the transplant center, if they have evidence for hepatic encephalopathy, cardiovascular instability, hypoglycemia or multi-organ dysfunction, these patients need to be admitted in ICU and they require continuous monitoring and need to be referred to an appropriate center whenever it is required. So the carry home message of this presentation is acute liver failure has high mortality without transplant or without spontaneous recovery. This extracorporeal therapy supports liver till organ is available for transplant or spontaneous recovery. Early referral or liaison with the transplant team is crucial. Thank you.